Good afternoon, everybody, and thank you very much to the organizers for such a wonderful educational treat during these days. And I believe the previous talk, 1 hour, was pretty good, pretty interesting, and quite knowledgeable. So I'll have to revise my introduction today. So after around 13 plus years being practicing in Delhi NCR Metro and 5 years, for last 5 years I was medical director with Fresenius Medical Care. Now since last 1 month I have moved to my hometown. So all of you must be aware of the land of Lord Krishna and Bihariji, Mathura. So we will be coming up with this 200-bedded multi-specialty hospital is ready, and most probably by next week or so, it will be on for services to be provided to the people. And with the blessings of Lord Krishna and Bihariji, let's start this session. So, I guess many of you and most of you must be aware in 1945 there was a woman who was a prisoner of war in German jail, and she got some sepsis, had an AKI, and there was this physician, Professor William Cuff, who had tried to treat previous 16 patients with some sort of renal replacement therapy, and he asked, could he do with this woman? And this was the 17th patient where a renal replacement therapy was tried and she survived. So this patient not only survived, but she has also opened a new window for the people globally for the survival from not only AKI but chronic kidney disease. Now coming on later on, there were multiple modes of advancements which happened, and India witnessed its first dialysis scenario in 1961 when a Maharaja of Jaipur had a dialysis, and there was a team of Indian and UK doctors who performed this dialysis. Now since then, I guess millions of patients have been getting dialyzed, but still, if I am today a huge nephrology community standing here, if we say that are we happy with our renal replacement therapy, specifically if I talk about hemodialysis, are we happy with our therapy, are our patients surviving? I'm not talking about one of 100 patients who is having on dialysis since last 15 years or 20 years. But still, most of our patients have a high mortality, and if not mortality, there is a high morbidity, hospitalization rate, complications, intradialytic complications. And this have always tried to pinch the brains of scientists and nephrologists that what is this we are missing. And as I talked about, that mortality continues to be high. And if we talk about tier 1 cities, it is high. In tier 2, 3 or 4 cities, it is higher and worst, and continues to be like that. And there are factors which came into picture when people thought about digging more that why this is happening. And this paper was an eye-opener in 2002, which proved or which said that in whatever way or whatever therapy you are doing, if the target is a urea removal, it is not contributing to the increase or improvement into the mortality of these patients. Now coming on, what is again, along with the mortality and other things, what is the problem when we are talking about the conventional hemodialysis? It's the intradialytic things which these patients face every time. And it is not related. We try to, when we cope up with many things, we try to limit the ultrafiltration to 12.7 ml per kg per hour. But still we see patients who are getting a lesser ultrafiltration with this, but still get an intradialytic complication. And specifically talking about those patients who have spent some time on a kind of a renal replacement therapy into a dialysis unit, maybe a year or two or so, and they specifically gradually again tend to decline and go back to their previous worst state where they ask their nephrologist, I'm not feeling hungry, I'm losing weight, I'm not good. The patient says, I'm not good. And this is something which we don't want and we don't like. Another limitation of the conventional hemodialysis, rather are those factors where we find these things happening to our patients. And if this is the big question, because this is a question which is coming to us, that what should we do to this patient or this pathology happening to this patient, and apparently we can't do anything. We try to increase the dose of the hemodialysis or we try to do factors, but it still doesn't work. For example, if I'm not going very far, I'm talking about phosphorus. Phosphorus being a smaller molecular weight toxin, we try a lot to do a good dose of hemodialysis, but it is not that much cleared, and which adds to the out-of-the-pocket expense to the patient. Yesterday, I saw a patient with a phosphorus more than 10. Now, the amount of money this patient would be spending on phosphate binders is an additional expense which this patient gets. And I guess, along with calcium-based phosphate binders, others are pretty expensive. Now, coming on annual crude mortality rate, I guess being Indian, most of the time, not only Indian, Indian subcontinent, people are very much fascinated about that. If anything best is happening in the world, it is America. So if we see about the annual crude mortality rate, it is actually not the America which is the best part, it is Japan. Now anybody, let's have a thing, my apologies if I'm asking a question, can anybody say why Japan has the lowest crude mortality, annual crude mortality rate? Exactly. So Japan started and modified its renal replacement or chronic renal replacement therapy. Sorry, sir. Usually I get chocolates, but I'm sorry for today, I'm not having this. But exactly, excellent answer. Before the world realized, when this was in process, Japan modified its dialysis structure. And another question I'm asking, beautiful and very intelligent audience, does anybody know what mode of HDF Japan does? It's unique globally. We'll talk about later. Japan is the only country where the maximum patients are on pre-dilution. Yeah, Japan is the only country. Still, they continue. Rather, we can't do it in a country like India. We'll talk about later about that. Now, coming on the contributing factors, we all know this has been studying since MBBS level, and then we continue to study in medicine and then nephrology, that we have accumulation of toxins which change the immunity and all that. But are these toxins urea and creatinine? Now, that question was raised by that paper in 2002, that clearance of urea is not helping. Now, what is the problem? Are we not targeting or are we not focused? Now, the point is that then came into the picture the other toxins which were there inside this patient, which gradually accumulate. Now I'm repeating another thing, that a patient comes to you who is CKD5, ESRD, you want to initiate dialysis. This patient says, I'm not happy, I'm not, and you counsel him that you will start hemodialysis after 1 month or 2, you will be good, you will feel happy. Now this happens after 1 month or so. But after 1.5 years or 2 years, again this patient comes to you and says, I'm not good. Why? Now the point is that the toxins which we are talking about, they are not abruptly rising in this patient. They are gradually building up. I'll give you a personal example. 3 years before I started my mother on dialysis, right? She had some issues. Later on, I thought of this thing and I checked her beta 2. It was more than 25,000. Unfortunately, I have shifted to Mathura because of my mother, because she was getting dialysis in another center. Now she'll be getting what I'm going to talk today. And rather I changed the filter. It helped me a lot, but not that of level. So apparently, in today's scenario, the toxins we are talking about, scientists have found more than 90 toxins of different molecular weight, which are gradually rising and positioned in the patient who has chronic kidney disease, irrespective of the stage of the kidney disease. Now these toxins, if you see, now again I'm putting up an example which cardiologists say to the nephrologists, that your patient pays you whole life and dies in my hands. They always say this, because most of our patients would have a cardiac mortality. And cardiologists, they are afraid of that. But if you see the toxins, they are specifically targeting those areas where this patient will be bound to have a cardiac mortality. And if you see the molecular weight, starting from 16,000 Daltons to 43,000 Daltons, and I believe these toxins are not going to be thrown out of the patient's body, specifically with the normal low flux hemodialysis. Now coming on the picture, there came a possibility of high flux dialysis. But again, a question coming, when we do a high flux dialysis, does it remove phosphorus? Yes or no? It does? No. You need to have a lot of things to do that, but phosphorus is still not getting removed. Why? Because the presence of phosphorus and the physiological property, the way phosphorus is present in this patient's body, right? And that's why many times the high flux membranes can remove lots of particles, but it also depends. Number one, the value of this molecule in this patient's body, and second, what is the cascade? What is the rate of release? If the rate of release is like that, high flux membrane might limit it but not succeed. So coming on the picture, now we have toxins of variable molecular weight which have to be targeted, and initially there were theoretical advantages because this is a newer therapy. Now coming on, what are the expected advantages from a therapy like HDF? If we are coming and going to adopt a therapy, one, obviously the clearance has to be on a wider molecular weight. It should not be restricted to a lower molecular weight. Second, biocompatibility. I mean, this new therapy should not initiate any other cascade of events which might increase the toxins or any other new toxins. And third, this therapy should continue to maintain or improve the hemodynamic stability of the patient. Now coming on again, evidence, another paper in 2001, if you see, the 1.4 membrane for diffusion, 2.2 meter square membrane diffusion, 2.2 meter square membrane diffusion with a higher blood flow, and last is hemodiafiltration. If you can see the prescription down, you can see exact 64% relative clearance is achieved when we are talking about a membrane in comparison to 1.4 to HDF. And I believe in a country like India, most of the patients are on a membrane like 1.4. Now, when we talk about only an HDF, obviously we are talking about a clinical scenario or clinical syndrome which has to be corrected. That means preservation of a residual renal function, intradialytic instability, Mia syndrome, anemia, hyperphosphatemia, and beta 2, which is a most common and accepted example of the middle molecules because of easy testing and availability. Rather, if I choose the best toxin to be choose, I will choose FGF23, but it is very costly to measure. Now coming on this graph, if you see how we have moved from a low flux HD, that means pure diffusion, to a scenario we are talking about HDF or hemofiltration, where we are completely changing the physiology of the therapy. Right? Initially we were kind of based on how the molecule is going to move as per the diffusion gradient. Now there can be many guests who will come into your house, but they will not go. Now you have to create some circumstances so that they can go outside without creating any chaos. And that's why if you see on the lower graph how the molecular weight is moving ahead. I'll not go into the details. Another part is the substitution volume, which I'll come. So when HDF came into the picture, very simple phenomena that people found, and I give always a best example of visualization, how HDF can be seen. Most of the people who have studied in hostel, we have washed our clothes. So if I have to wash a shirt, the first thing which I will do, I will dip it into the water. So I have added a solvent. Then I will put a soap. It is a solute. I'll try to put it, this is TMP, but this does not removes all of the soap. Now what I have to do? I have to again dip it in the water and again put the pressure. So I am adding lots of solvent, which takes the soap, which is a solute, in two ways, either by diluting it or either by its flow. And this is how HDF works in our body. Right? Pre-dilution or post-dilution, we are putting lots of fluid into the patient's body as per the prescription or dose, and this fluid, by the help of the pressure, is removed through the dialyzer, which creates a two-way system. One is by dilution, second is by the flow of the water. Now coming on comparing the lowest therapy, which is a low flux to the kidney, we are far lower. But if you want to compare high volume HDF towards kidney, rather it is still a long way, but something we are achieving, right? Now HDF, what is HDF? It's a combination of diffusion, convection and absorption. Rather, absorption is not that much significant in this scenario, but absorption happens everywhere. So this, I have given you an example, right? Now coming on another study, if you see comparison of urea, beta-2 and amylase. No, HF is always come. Why? Because if you want to talk about urea, which is smaller molecules, the better clearance is by diffusion. But if we talk about the higher molecules, the better clearance is always by a convection. Now HDF can be of two types. One is online, one is offline. Online, where you are producing your fluid at home, that means in your unit, and offline where you use bags. So there are machines which are available where you can use bags, but that becomes a very costly scenario for a country like India. Right? The freedom of treatment is that you can perform hemodialysis, hemodiafiltration pre or post, and hemofiltration pre or post depending upon what is required. In pre-dilution, very easy, the blood coming out of the patient, you put the fluid before it enters the filter, right? And then this fluid goes through the filter and again is removed out along with the desired ultrafiltration. It is a very safe therapy, keeps the hemodynamic status good, but gives not very good results. One, because you are diluting the blood. And second, to perform a pre-dilution, the dose is very high, which you cannot achieve with the kind of fistulas which are available in the country, right? Second, most common use or most common mode of HDF across the world is post-dilution, where the fluid is added when the blood leaves the filter towards the patient. Here, the dose is not that much high, but you are not diluting the blood, and thus the same thing goes into the patient's body and the clearance is happening within the filter, which gives a very, very excellent and good results in terms of the requirement of achievement over the wider molecular weight range. So blood is undiluted, as I said, the limitations are high blood flows are required. Now high blood flows are required, why? Because HDF is usually based on a dosing system. When we talk about HDF or online HDF, the dose is 21 liters. When we talk about high volume online HDF, the dose is 23 liters. Again, one question, if I want to achieve a dose of 23 liters and my desired ultrafiltration is of 2 liters, what should be the actual dose given to the patient? My required total dose is 23 liters. My desired ultrafiltration from the patient is 2 liters. What should be the dose given or prescription given to the patient? It should be 21. So there is a confusion. I don't say that everybody of you has, but I have seen this, that the total ultrafiltration has to be counted, whether it is the desired or the achieved. So the 23 liters is the dose of desired ultrafiltration plus what you are prescribing. The post-dilution mode, as I said, is the most commonly used and most prescribed mode of treatment globally. Now coming on, if we see this picture, we cannot imagine this picture when we are talking about hemodialysis. Right? Now our criteria have improved, our expectations are improved in terms of therapeutic outcome of the patients or what we are expecting from the patient after this therapy. But the first point is very important, that as we dialyze the patient and there is a reduction in the urea and creatinine, we cannot expect the same thing happening with HDF or middle molecules. It takes time. So we don't expect, and that's why when you are initiating a patient, before initiating we check the beta-2 levels, then we check at 3 months, then 6 months and going on. Because it takes time for the reduction, because as you are reducing the beta-2 levels or the middle molecules, you are also reducing the inflammatory markers. So it goes hand on hand. Right? Now coming on, this I have discussed, so I'll go into the, I have less time. So what are the benefits of HDFs? So it enhances uromic toxin release, reduces the interdialytic hypertension control. I have seen patients who have absolutely stopped their antihypertensives or phosphate binders, facilitates anemia control, reduces inflammation, improves bone disease and most of the time, the biggest out-of-the-pocket expense from the patient is hospitalization. And we have the study which has proven, the Catalonian study, which has proved in a very, very perfect and nice way how this kind of therapy is improving not only the life or the mortality of the patient, but also their quality of life. The last point is that we have to use a very specific dialyzer. That means a dialyzer which has a higher ultrafiltration coefficient along with the pore size. Only pore size will not matter. I have seen some places where a high flux dialyzer is used for HDF. It will not work because you need a higher ultrafiltration.
Can you hurry up?
I'm done, sir. So that's all, I guess, in a limited time. I could try to give you the best of the things. I'm open to the questions. Thank you very much.
Can you elaborate the cost factor, capital and recurrent?
So there is approximately, the cost factor is approximately 30 to 40% expensive than a hemodialysis. Why it is expensive? Why? Because the machine is costlier, the tubing is costlier, and you require more fluid than a normal hemodialysis. But I don't say, because I have patients on hemodiafiltration. Over the period of time, this cost of 500 or 800 rupees extra in a treatment. On the long term, it reduces the out-of-the-pocket expenses from the patient. So as per me, as on a long-term basis, it is a cost-effective therapy. I don't believe that it is a costly therapy. Initially, yes, can be seen. But if the India is a country where the iPhone 14 released and a person can fly to Dubai and get it, I guess in a therapy where we are putting up a long-term beneficial effect, we should not think that on the day one that it is costly.
You can elaborate on the experience and comments.
Yeah, Dr. Ashish, online hemodiafiltration has been in discussion for several years now. Do you think that there is enough data to say that it is better? I mean, you said the Catalonia study. How many patients were in that study and what was the follow-up?
So, number of patients, I don't remember, sir. But this was a study which was done in Europe. Number of patients was pretty good and follow-up is still there. By this year end, there is another study which is going to come, which is happening in UK. And up till now, my knowledge, the results are very promising. This is the first part. Second, as per my experience in last 6 years with hemodiafiltration, not only in India but globally, including my patients, I have approximately, when I was in Fresenius, I had more than 200 patients on HDF. And otherwise also I have seen patients on HDF. Also I have talked to the nephrologists who are doing HDF. The quality of life and the other factors drastically improve. So yes, there is a sure clinical benefit. It depends upon country. A patient in Europe and a patient in India is clinically absolutely different. Same with the dose. If you are not providing the dose, that means 21 liters or 23 liters, and we expect results, that is not going to happen.
Yeah, no. Basically, what I'm trying to emphasize is that still there is not enough evidence to actually make conclusions that survival is better. Anyway, in Japan also, you mentioned about that 6.3% mortality. Transplant rates are very low in Japan, and that is one of the major reasons why the mortality of ESRD, dialysis patients in Japan is quite low. I know there may be other factors also. So I don't know whether the data that you presented were all after HDF use or before.
Which one, sir? The Japan?
Japan, US and UK.
So Japan started HDF long ago. And initially their HDF system was not which is now today. They designed their own system, and that's why it was pre-dilution, right? And second part, in Japan and countries like Japan, Korea, you don't find that much HDF or other things because they are very fixed policies, like PD first policies there. Even a patient, if it is the prime minister of the country and he does not qualify for other therapy, he will have to go to PD. So that is the point. In Hong Kong, it is a PD first policy.
And Dr. Dinakaran.
Dr. Dinakaran?
Yes. The pre-dilution versus post-dilution mode of hemodiafiltration. Personally, I have used more of pre-dilution mode, using about 25 to 30 ml per minute of the dilution fluid. And I found that it has less hemodynamic instability and the clearance was also good. That is one thing. Another factor that adds to the cost of hemodiafiltration is the requirement for ultra-pure water. You have to have 2 RO systems in sequence. The regular RO system used for dialysis plus one more RO system, so that you will get a better water that improves the performance of the hemodiafiltration. The third one is the hemodiafiltration need not be exclusively used for some patients. I have tried it in some patients. We do 2 hemodialysis conventional and add 1 HDF as the third dialysis for him, and I see some improvement in quality of life. That reduces the cost and improves the compliance of the patients.
I agree, sir. The first, I'll answer the 3 things. The first thing, pre-dilution mode is reserved for selective patients like cardiomyopathy. If the patient has a poor ejection fraction, he can only get a pre-dilution mode. Second, it is for CLD patients with a huge ascites or portal hypertension. They cannot tolerate a post-dilution. And so that's why pre-dilution. Otherwise, second, sir, in HDF, we don't do it as a 25 ml per kg body weight. It is for CRRT, reserved for CRRT. In HDF, if we are talking about the dose, post-dilution dose is minimum is 21 liters. If you want to do it pre-dilution, it is 40 liters. To achieve those molecules or those status where you are having it. Now, it also have to see that have you checked the beta-2 levels? I have seen patients whose beta-2 levels were normal. 2 days back, I saw a patient whose beta-2 level was normal. If I do HDF 6 months back, after his beta-2 is going to be normal. This is the first part. Second part, I'm sorry to sir, but there is no extra penny spent to create an ultra-pure dialysis. If you are following ISO 23500 guidelines, any local made RO, if it is designed as per now the RO is regulated in India. Initially, RO were not regulated in India. Now, dialysis RO is regulated. So anybody cannot give you a undesigned RO. A normal RO with a proper maintenance give you ISO 23500 dialysis water, where the CFU is less than 100 and endotoxin is less than 0.25. When it mixes with the part A and part B, it becomes the ISO 23500 dialysis fluid, where endotoxin is 0.5 and CFU is less than 100. Now, next point which is very important, whether you do hemodialysis or hemodiafiltration. The UPDF or ultra pure dialysis fluid is achieved after the dialysis fluid passes through the DISAFE or the endotoxin retention filter.
I think you'll have to take the next questions from the audience.
Thank you. Any other
UPDF
questions, please?
Yeah, I think
Last one question.
So the membranes have undergone a lot of improvements, the filters. So I used the Art Plus machine, the Baxter Art Plus machines. We used to do the HDF. So now Baxter said, stop HDF because we are, you don't have to require doing the HDF. We are giving you the filters by the name of Terranova 500. So Terranova 500 is as good as HDF without requiring. Now they have proven some trials, there are RCTs on that. So I think that's the way forward, where you don't have to change your membranes.
I'll answer sir that.
Yeah.
So now I'm individual and independent, so I mean Baxter won't mind. Indeed, Terranova is a good dialyzer, pretty good dialyzer. But you see the clinical studies, the Terranova comes into a dialyzer which is middle cutoff membrane. But all the studies, if you will see, which have been done, they have been done on a bovine blood, not human blood. This is the first factor, and second, the studies have been done with the ultrafiltration of 10 or 30 ml, right? So the comparative thing is not good. And the last point, just the first question coming from sir, Terranova, the cost is 2,500 rupees. Even if you do anything, the cost is not going to be cheaper than HDF. It is going to be at least 1,000 rupees more than HDF. But yes, Terranova is a pretty good filter if the affordability is not a problem, and you don't have a HDF machine and you have an HD machine and your patient can afford, Terranova is a pretty good machine. But the HDF, it is not HDX. Terranova is HDX. It still works on diffusion. You cannot remove all the molecules of middle or higher molecular weight by diffusion. You need to have a convection because that is separate physiology. So Terranova is totally a different thing because it works on diffusion. Rather, membrane comes into the another category. But I agree, if the patient is affordable and you can have that cost factor, you can do HDX. I am doing this, so that's not a problem.
Thank you, Dr. Ashish Sharma, for a nice presentation
The
on
last question.
STF.
The last question.
Thank you. With this, I close the session.
Yes, sir.
I just wanted
Thanks,
to know. in
Speaker
our-
and the chairperson. May I request our chairperson to kindly honor the speaker, please? And Dr. Prabhakaran to honor the chairperson.